So I'm Kim Weeks, and I've had the privilege of being in general practice for 25 years. And for some of this time, I've worked as the practice nurse. I'm now the co-owner of the practice that Andrea works in. We're a 9 GP rural practice. I've a great passion for all things nursing, so I'm not quite sure how I've ended up sort of removed from that a little bit, but that's okay. I do still function. I particularly have a passion for nurses in primary care, and I often wonder how practices who don't have them actually manage. I'm not sure they would. My absolute support of general practice nurses is what brings me here today and allows me to introduce Andrea, who's one of our practice nurses. She belongs to a team of 5 nurses, and they each have their individual place within our practice. But the one thing they do have in common in our environment is that I give them artistic licence. So I encourage them to bring me ideas, and we work on turning them into realities, and that's what Andrea's done today. And she's here to present her most artistic idea. Together with a team of GP tragics, like the rest of us at Marama, we turned this into a reality. Over my time in general practice, I've really learnt that giving ownership of things to people provides great results. And nurse-led initiatives are a great example of this. We focus on what's good and what's in it for our patients, not what's in it for us or what's in it for the practice. It's about what's in it for the patients for us. And the theme of this conference, I notice, is about inspiring and facilitating personal career progression, shaping and strengthening the profession of primary care nurses, and this is what you all have to do. I believe that the day is not far away where primary healthcare nurses will actually outnumber GPs. And it was with great enthusiasm I listened to our support staff this week, because like every other practice at this time of year, we've had a really busy time of it. And I heard one of the patients saying, "Can't I see the nurse?" And the receptionist said, "Well, they're actually more booked out than the doctors. So how about you see the doctor?" She said, oh no thanks, I'll wait for the nurse." I wish we recorded our telephone conversations. At Marama, we've got a really strong focus on a team, so no one person in our team is any more important than anyone else. So doctors and nurses, we say, go hand in glove, or actually my co-owner says that all the time. She's a GP, and she says that she believes nurses and doctors are hand in glove. I kind of don't want to ask her which one we are, because it might turn into a little bit of an argument, that one. So if you take nothing else from Andrea's idea today, take this, that you are a valuable resource in primary care, and you need to show the fraternity that what you do is paramount to patient care. So go out and find your most artistic idea, be passionate about it, and then do what Andrea has done and turn it into a success. Now, for anyone from my era, I get to play Delvine Delaney now. So I'm just going to step aside in my little Delvine outfit over here, and Andrea will let me know when she needs me.
However, I'm hoping I'm not Tony. It's okay. Hello, everybody. My journey as a practice nurse actually began completely by accident. I had just moved to a small rural community, and I was in the post office posting a job application for a non-nursing position, and got chatting to this lady who was standing in the queue with me about sand art, of all things. And we had a lovely conversation. She said, "Oh, look, would you like to come round for coffee tomorrow?" And I thought, "Oh, great, I don't know anybody in town, that sounds lovely." She said, "You can meet my husband." "Oh, that'll be nice, yeah." So I went round the next day. Turns out her husband was the local GP, and I got coffee and a job. So, totally by accident. And as many of you will know, back in those days, it was a learn-on-the-job situation, so I was very unsure. But I have been very lucky to have worked in general practices that have been incredibly supportive of their practice nurses and have definitely valued the contribution that we make to the team. And I'm still there. I was still at a practice that supports me, basically. I believe that for me, my job is to help people be the best that they can be. I love the variety that is in practice nursing, and I definitely see that we need to continue education and we need to continue to learn every day, and that's why these conferences are a great opportunity to learn from our peers. For me, that's one of the best learning experiences that I can have. So I came up with this idea for the bone health clinics after reading about a clinic in the Reframe Osteoporosis newsletter, and that inspired me to look at our statistics for bone health and our patients. So if patients fall over and break a bone, they're never ever going to be as good again as they were the day before. So our aim for the bone health consults is to help them be happy, healthy, safe and at home. So that's the beginnings, basically. Thanks. So Delvan's doing very well over there. So 2 out of 3 Australians aged over 50 have osteoporosis or osteopenia. New South Wales and ACT last year, 150 fractures every day among older people. Total cost in New South Wales last year, osteoporosis, osteopenia over 50 was 1.1 billion, and 740 million of that was related to fracture treatment. The stats are amazing. 20% of people will die within 12 months of a hip fracture. 50% will refracture if they have a minimal trauma fracture, 50% will refracture and they're at risk of premature death. This blew my mind. The risk of hip fracture for women is higher than the risk of breast, ovarian and uterine cancer combined, and greater than the risk of prostate cancer for men. But it's not publicised as a big problem. So when we were looking at opportunities for group consults, we also considered that osteoporosis was essentially a non-threatening disease for patients. It's not because they ate too much, it's not because they drank too much. So to be able to talk about it in a group situation, they're more prepared to do that. So osteoporosis means porous bones. Often the first time we may become aware that we've got osteoporosis or osteopenia is with a fracture. So a low impact fracture is a fall from a standing height, like a fracture from a trip or a stumble. From the outside, we can't tell our bones are not as strong as they should be. Delvene Delaney is now going to demonstrate. Do you want to come around this side? Yeah. So what we have here is a pretend osteoporotic bone and a non-osteoporotic bone. Okay, Kim's going to drop them from a fall from a standing height and we'll see what happens. Okay. Yay! So she's now going to demonstrate the effects of that. So the Milky Way, which is the normal bone, is beautiful, intact, no problems. The Crunchy, which is the osteoporotic bone, is in pieces. So we actually use that tool in our bone health sessions just to demonstrate to patients the difference. Yeah, and then they get a little snack at the end of it, so it's actually quite good. So our bone health sessions target patients at risk of osteoporosis. The aim is they increase disease awareness and provide education. We increase the screening, identification of disease and treatment. We reduce the fractures and complications of disease, including early death, and we promote healthy ageing. So they were identified as a way to help the practice move towards the healthcare home and integrated care, and they're a great opportunity for preventative care instead of waiting till the wheels fall off. If we can help them improve their bone health, then maybe they don't fracture, maybe they do have a better quality of life. So we had to start with the very basic, same as always, clean up your data. We got some statistics regarding our current screening rates, fracture rates, our current rates of osteoporosis, osteopenia, and we were very successful in securing some funding from Coordinaire. and the project's actually being evaluated by the University of Wollongong. So I came up with the plan, and I went and had a chat to Kim, who was very supportive of the idea, and we decided to start with a focus group. So our focus group was 4 patients, 2 men, 2 women, dietitian, exercise physiologist, Kim and myself, Linda from Coordinaire, and Bridget from University of Wollongong. And we put the idea to them, what the proposal was, what the format was, and what they thought, what would work, what wouldn't work. The patients were stunned that we would actually ask them what they wanted. And we actually made changes based on that, because we initially had it spread over a longer interval of time, thinking that that would allow time for patients to have bone density done and, interact, have some changes and things. The patients actually felt that that would extend it out too long and people would lose interest, so we condensed it into a shorter time frame, and it now usually happens in about 2.5 to 3 month interval. We finished the 3 group sessions in that time. They're small group sessions. They have sort of 8 to 12 people per group. There's 3 sessions. They involve the nurse, the GP, medical practice assistant. We have 3 trainee medical practice assistants in our practice. We're very lucky. A dietitian and exercise physiologist. So patients are actually asked when they're invited to make sure that they can attend all 3 sessions, because they all cover different things and they need to be involved in the 3. If they miss one, we try and slot them in on that session in the next group, because they are trying to be run continuously. There's no charge to them, and we actually use the Reframe resources to run a lot of the sessions with. So please go and see the Reframe team when you finish today, because they have some excellent resources. And our GPs are actually planning to participate in the Reframe clinical audit as well. So the medical practice assistants, as I mentioned, there are 3 of them undertaking the course, and they're helping with the project. So they are involved in inviting the patients, confirming appointments. They let them know about the session times. They help with the setup of the sessions, all the patient folders and information booklets. They greet the people, and they do a height, weight and a smoking status on people when they first arrive, which helps with the clinical audit as well. And during the sessions, they help the patients complete any forms, because we do the Garvan fracture risk tool and some full self-assessment, that sort of thing, so they help that. They're also a great point of contact for the patients. So if they ring up and have any queries, or they, not sure about anything, they know that medical practice assistant is their first port of call, and she will help them out from there. We have 1 medical practice assistant allocated per group, so they do the 3 sessions for that group, and then another one does the next group, so that they're all sort of getting a turn, basically. So the target group is patients over 70, because we had to condense it to something that we could take an actual bite on. We sent out invitations by SMS, which was, actually worked really well. The first one, not so well. We got some responses back. Sent the second one, we got heaps of responses. Apparently they all thought the first one was spam. So they didn't respond, but I did do the wrong thing when I sent the second one out, because I sent it in a batch and it was over the lunchtime, and the girls at reception got inundated with phone calls, so I'm not allowed to do that again. You just pick your time a little bit better next time. So the funny thing was, when we sent texts out to what we were inviting the husband this particular time, if it was a communal mobile and the husband and wife shared, the wife always thought it was for her because it didn't actually have a name on the SMS, it just had the actual invitation. So next time we've decided to adapt to that, and if husbands and wife attend the practice, we'll invite both at once. We've actually got, we've had 2 husband and wife teams complete the sessions so far, and they've been quite comfortable with it as well. So if patients phoned up and they declined, the most common reason was because they couldn't attend all 3 sessions. They had some other commitment that didn't allow them to attend on that day. So we've kept a record of them, and we asked them would they be happy to be re-invited in the future, and almost all said yes. So we're building a base list for future ones as well, so that's also helped. So just to give you a little bit of an idea of how we run them, session 1 it runs about an hour. They have their height and their weight done by the medical practice assistant. We give them some basic osteoporosis and osteopenia information, and we use the Reframe patient education slides for those. They're given a bone density screening form if they haven't had one in the relevant time frame, and they're asked to have that done prior to their next session, so that when they come for the next session we will know what their results are. And they give written permission for the clinical audit. Yep, sure. Sorry, I'm running over time. I'm trying to be quick, guys. So session 2 covers risk factors and prevention of osteoporosis, and we use the Reframe Managing Bone Health Action Plan booklets. We go through those with the patients, and we do goal setting, roundtable discussion. They complete a self-assessment on falls risk. They're given information about the local falls group. They do a Garvan, the medical practice assistant helps them with the Garvan fracture risk tool, and all of that information is scanned to their file so that when they see the GP about their results, they've got that full comprehensive information there with them. So then session 3, we knew we'd been successful after the first session because the radiology clinic around the corner phoned us and said, please don't send everybody all at once. The patients had actually left the sessions and gone straight round there to book their bone density testing. So that was really encouraging. We thought, yes, we're on to a winner. The third session's held about 2 weeks after the second one. And we actually have a dietitian and exercise physiologist come in for these sessions. So we split the groups in half, and they spend an hour with each, and then they swap. So the dietitian takes them through eating for bone health, but also eating to optimise ageing. And then the exercise physiologist also takes them through an exercise program. So we have an area. They're told to wear comfortable clothing so that they're able to participate in that. And we also do an evaluation form at the end. And so far the results have been really positive. So we've had 2 groups complete so far, and we've got a third session underway. Feedback, as I said, has been really good. So patients who miss a session, we slot them into another one. One participant was actually really concerned at the start that we would be pushing medication and medical treatment for osteoporosis. Ex-nurse, very anti-medication, not interested at all, and we reassured her that it's actually not about that. We don't discuss medications at all. At the end of the second sessions, patients get a handout that is confidential, their own little one, that says, your results show osteopenia or osteoporosis, please see the medical practice assistant, you need to see the doctor. Or it says, your results are normal, congratulations, you have great bones, keep up the good work and keep coming to the sessions. So yes, she was really anti. So she has actually come up to me afterwards and said, that is fantastic. There was nothing about medication. I feel that I can do, there are things that I can do. And I believe that there was one person who wrote on the evaluation form, after these sessions, I think I will go and see the doctor about medication. I'm guessing it's her. Not sure, they're confidential, I don't really know, but I think maybe. So.
2 minutes.
Okay, success measurement. Basically, we'll be looking at our patient survey results, we'll be looking at our bone density screening rate, we'll be looking at our coding and improvement of diagnosis of osteoporosis, osteopenia. We're also recording the number of care plans that will be generated as a result of this identification, and referrals to the dietitian, exercise physiologist and the falls group. So we hope that the sessions can run on a continuous basis, and the model, if it's successful, can be adapted and used for other disease conditions. So other practices can use the methodology for their own improvements and to improve patient outcomes on a much wider scale. So the bone health group sessions actually do enhance nurse leadership because it is a new nurse-led project, and the GPs come in as they are needed and they see the patients regarding their results, but most of the consults are run by the nurse. So you can see I've put up the resources there. Please have a look at them. They are fabulous resources for osteoporosis. And just in conclusion, in our practice, Kim is very used to me appearing in her doorway saying, "I need to talk to you, I had a thought." We all have great thoughts and ideas, and the difference is voicing and acting on them. I know not everybody works in a supportive environment, but I would encourage you to have courage and speak out. We are patient advocates, and your ideas could make a difference to your patient, yourself, and the wider health community. So, thank you.